Good morning, Peter Goertz. I'm a psychiatrist. Some clinical tidbits regarding prescribing psychotropic medications. I gave a brief presentation last week at work, and here are some situations that are worth talking about. Prozac and Wellbutrin, prescribing them together can be a problem because Prozac inhibits P450-2D6, the enzyme, and that potentially can increase the level in the blood of Wellbutrin and potentially can cause a seizure. Unfortunately, that may have happened with a patient of mine. I'm not sure if that was the mechanism, but potentially. He was a young gentleman, started on Prozac, I think then Wellbutrin was added, and then maybe the Prozac was increased, and that was just too much maybe. And the poor young man, I think he was 19 at the time, had a seizure. Now, theoretically, that can also occur with a combination of Paxil and Wellbutrin and with a combination of Zoloft and Wellbutrin. At higher doses, both Paxil and Zoloft significantly inhibit P450-2D6. Lithium drug interactions are quite common, and the main ones to remember are non-steroidals and thiazides. They can markedly elevate lithium levels. I once saw a lady who was toxic from lithium due to taking Motrin with lithium. And there are many other drug interactions with lithium, but those would be the two main ones. If you just remember two to recall. Sweating can also be a problem with lithium. The way I think of it is sodium and lithium are reciprocal for the kidney. So if the level of lithium goes higher, the level of sodium in the blood goes lower, and vice versa. So if you, for instance, sweat a lot and lower the sodium level in the blood, then potentially there may be lithium toxicity. Analogously, if you go from a total salty potato chip diet to a vegan diet with very little salt, you might, because you're lowering the sodium level in the blood, you might increase the lithium level in the blood. Clozapine, you want to remember seizures. So what happened to me once on an inpatient psychiatric ward is I was called by the nurse saying, so-and-so, a patient is looking dazed and confused, and probably he was post-ictal, so had a seizure on the ward. So the incidence of seizures with clozapine can be quite high. I think at a dose of around maybe 500 milligrams per day or 600 milligrams per day, the incidence might be 5% seizures. So something to pay attention to. You don't want to forget, clozapine can also cause cardiomyopathy, myocarditis. Drooling is a major issue potentially with clozapine. Tachycardia. I had a patient not that long ago who was doing reasonably well psychiatrically on clozapine, but developed tachycardia, which was quite troublesome. And his primary care doctor put him on a beta blocker, and even then his heart rate was somewhat marginal, if I recall correctly. And ultimately we ended up stopping the clozapine because of adverse effects, for instance, the tachycardia. Because of the heart issues potentially with clozapine, you may want to check a troponin if you have any suspicion, for example, with a patient on clozapine. With stimulants, my process in evaluating a patient who may be asking for stimulants or whom you may want to prescribe stimulants for, my process is to get collateral information because it's important to know whether the patient had potential ADHD already in childhood or not. So that's important. And based on the DSM-5, the diagnosis of ADHD is made based on collateral history, based on longitudinal history. And in order to get the longitudinal history, because patients were children when the symptoms are, as per the DSM, usually starting. So you usually want to get longitudinal history or collateral history helping you with longitudinal history. So collateral history, for example, from a parent or an older sibling can be very helpful. And I generally don't routinely ask for psychological testing in someone whom I'm thinking of starting a stimulant on. You may want to do a physical exam. My process at this point during visits of patients who are taking a stimulant is to routinely just listen to their heart, just briefly. I check their pulse and heart at the same time with the stethoscope. And so I palpate their pulse and check their heart with the stethoscope. And that can be helpful. You do sometimes pick up things. Getting an EKG once they're on a stimulant is helpful, in my opinion. You want to check for arrhythmia. And elderly patients, I generally try my best not to prescribe stimulants for. In fact, I get a pop-up in the computer if I'm trying to prescribe a stimulant for like Adderall for an older patient, for someone 65 or older. I generally get a pop-up saying, please don't do that. Now, prescribing benzodiazepines, I have a patient whom I inherited from another psychiatrist. He was already on Xanax, a total of 6 milligrams per day. And I've continued to prescribe the Xanax 6 milligrams per day for that patient. He also at times takes an opioid medication, I think once a day at least. So potentially it's a problem with his breathing, combining the Xanax with opioids. He, however, has tried other medications, I think Celexa, Lexapro maybe, and nothing has been successful. So I've continued that patient on Xanax. And it's not a great situation, although I do feel this patient is not abusing the Xanax. But the Xanax can be a tricky medication when it wears off. That wearing off of the Xanax itself potentially can cause anxiety. Now, many psychiatrists are hesitant to prescribe Xanax or other benzodiazepines, especially if someone is being prescribed an opioid. The other side of that coin is a patient of mine told me that her brother had been prescribed Xanax for many years, and then his doctor did not want to prescribe it anymore because he was on an opioid. And then unfortunately, the brother of my patient killed himself. And part of the reason may have been that he was off his Xanax and not psychiatrically stable. One basic thing to remember when prescribing benzodiazepines is if someone has liver impairment, you want to probably go with LOT. Remember LOT, lorazepam, oxazepam, or temazepam, because those benzodiazepines are glucuronidated in the liver, not otherwise metabolized, not, for example, oxidized. So they tend to be preferable if someone has some hepatic impairment. And what strikes me is how different patients are regarding potentially withdrawing from benzodiazepines. A patient of mine who was on Klonopin for years, she did better, actually. It's interesting. After her husband died, it seemed like in some way that was a relief for her. He may have been controlling, and she did quite well psychiatrically after her husband died. In fact, she was able to really decrease the amount of psychiatric medicine she was on. And if I recall correctly, she was even able to get off the Klonopin. And again, some people have a very hard time getting off benzodiazepines, and you definitely, even if the patient has an easy time getting off benzodiazepines, you still want to taper. You don't want to cause a seizure by abruptly withdrawing benzodiazepines. And benzodiazepines in the elderly, you really want to try and avoid. They can cause confusion, falls. In pregnancy, you probably want to avoid them, or I would avoid them because there have been reports, if I recall correctly, of cleft palate due to Valium. So with any psychiatric patient, if you do an initial evaluation on a psychiatric patient, you want to ask them if it's a female of childbearing age, do you want to get pregnant anytime soon? And that can kind of guide you in prescribing. If someone is pregnant, SSRIs can cause potential problems, especially Paxil, which has been reported to cause atrial septal defects and ventricular septal defects. That has been questioned down the road if that report was as significant as it seemed to be initially. Lithium can cause Epstein's anomaly of the tricuspid valve. What's Epstein's anomaly? Downward displacement of the tricuspid valve with potential tricuspid regurgitation. Depakote can cause neural tube defects in pregnancy, so neural tube defects in the unborn child. So you really want to try your best to avoid prescribing Depakote in women of childbearing age. But years ago, when I spoke with a psychiatrist who specialized in prescribing psychiatric medicine in pregnant women, she said that's not an absolute issue. So if someone has bipolar disorder and gets very unstable without Depakote, as per her, that still was acceptable to potentially prescribe, but I would tend to avoid that if at all possible in pregnancy. Tegretol we want to try and avoid in pregnancy because also it can cause neural tube defects. Haldol during pregnancy supposedly is reasonably safe. However, you can always get blindsided. I remember a patient on a psychiatric ward, hospitalized on a psychiatric ward, was pregnant, and she received Haldol over her objection while hospitalized on the psychiatric ward. And I learned later on that she killed herself after discharge. And I wondered, in hindsight, if that patient, because she believed that the Haldol could harm her unborn child, so she really was against taking Haldol in pregnancy. And I wondered in hindsight if her suicide had something to do with her being very upset about having taken Haldol in pregnancy. If someone is pregnant, if a patient of yours is pregnant and on psychiatric medicine, you want to ask them, are they wanting to breastfeed after the baby's born? So that can guide your process of prescribing after the baby's born. QTC prolongation can be an issue with antipsychotics, for example. Abilify, to my knowledge, does not prolong QTC, so that's a consideration. And used to at least be a consideration for PRN, medication for agitation in pregnancy, but I think the intramuscular injection form of Abilify has been discontinued by the company. Now, hyponatremia can be an issue with Trileptal. It can be a major issue actually with Trileptal, and can be an issue with Tegretol, a little bit less so than with Trileptal. It can be an issue with SSRIs, SNRIs, and second generation antipsychotics. Tegretol can cause enzyme induction, which can be an issue, let's say if a lady of childbearing age is on birth control and you give Tegretol, that may decrease, due to the enzyme induction, may decrease the level in the blood of the medication the patient is taking for birth control, and the patient might get pregnant while on birth control if she is taking Tegretol. Depakote can cause what appears to be potentially a rash, so you want to always look closely because that rash might turn out to be actually petechiae from thrombocytopenia. So Depakote is known to not infrequently cause thrombocytopenia, Usually not that bad. Usually, I'd say 100,000 or more, the platelets remain, but potentially less than that, and that thrombocytopenia, if it's severe enough, might cause petechiae. So little spots due to small bleeds in the skin. Risperdal is a major offender, potentially in elevating the level of prolactin in the blood, and that potentially can cause impotence. I remember a patient of mine way back in a clinic. He wanted to try risperidone. That was around the time when it came out. He wanted to try that instead of Haldol, which he'd been stable on for years. And then he noticed on the risperidone, he noticed that when he tried to masturbate, he had trouble getting an erection, which may have been from elevated prolactin due to risperidone. And if I remember correctly, we may have switched that patient from the risperidone back to prolactin. So those are some quick tidbits regarding prescribing psychotropic medications and various aspects that can be of practical relevance when you prescribe psychiatric medications to patients. Thank you very much.